In this episode on knee pain with running, we're actually going to go over IT band syndrome. IT band syndrome is a common injury plaguing runners, and I'm going to show you 7 different ways that we actually treat it right here at Performance Place. Here we're going to be looking at the IT band here, so in case you're wondering about anatomical structures, I'm going to try to break this down in a real easy way. Let's go right here. So we have the knee cap. You can tell it's the cap because you can grab right onto it. Okay, right above that is the quad. We have the lateral quad on the side, which a lot of people think this is the IT band, but realistically it is majority of the lateral quad, which is called the vastus lateralis, and just superficial to that on top is the IT band. Now the IT band goes and attaches down here. Okay, so we're going to bring this thing down, and you can actually see if you grab onto these structures right here, you're going to see that, so you have this divot starts to form right here. You can see it up her quad right there. So that is her IT band, and I'm grabbing onto the back side of it. So if we take this and trace it down, we're actually going to get all the way into the shin bone or the tibia right here. And this is usually where people will have IT band or iliotibial band syndrome at the knee. It can happen further up the leg, but for the most part, iliotibial band, you can grab it right there. It is that very superficial structure, and it's important to differentiate it between lateral meniscus pain and IT band pain. So for mobilization of the actual knee, we're going to be working on the actual ball and socket of the knee. Okay, we can work on other parts as well, but this is a really good way to mobilize, getting more external rotation, internal rotation, and also axial compression, which we're trying to get the backside of the joint capsule. So the joint capsule is actually made of ligamentous structures, and actually she's got some good flexibility here, but in regards to showing you how to treat it, I will go over it anyways. So usually what I'll do is we'll check external rotation, we'll check internal. We'll actually go into a Scour's test, which is almost bringing the knee up and across, looking for any pinching, any restriction that she might have, and also coming even a little bit wider and pressing in this direction, so going down the thigh. So usually when we find something, a lot of people actually don't have the proper amount of internal rotation, and they really hang up here. You can actually see their pelvis start to raise, and they'll kind of shift their back around. So what I like to do is I internally rotate, and I drive down. So we're actually pressing down the femur or the thigh and adding a little bit of oscillating internal rotation. I usually like to do this for about 30 seconds or so, and obviously looking at her face to make sure that she's not going to cry or it's too painful. Or pass out. Yeah, she said or pass out. I don't know if they can hear you on the mic. Same thing with external rotation here. Axial compression and adding external rotation again. And also too, I think it's important to get them into a little bit of circumduction here, and you can also add the same thing. So find out where your restriction is. Here, drive in, and then internal rotation. Now we're going to do some tissue work onto the quad areas. It's nice to release the quad, especially the vastus lateralis, because it's just underneath the IT band right here. Okay? So a lot of times I like to hold the structure, and sometimes you can do a broad contact, which I like to do to start with. And then I like to move their leg. I'm using it with my knee down here. I guess you can't see in the camera. So just doing just holding it really firm and just letting all the muscles really pass through. Just getting some slide amongst the structures, and then you can reverse that. So I'm going to bring her leg out now. I'm doing most of the treatment with my thumb right here, just because the IT band's going to pass straight through the area. Now obviously we're not in the section of the knee which the pain is at, but a lot of times I like to treat and troubleshoot. If you can work up and around the area and also below it, a lot of times you'll get a good amount of relief without actually irritating the location of the irritation currently. If you want to go down lower, you can obviously trace the IT band down with the same method we palpated with. You grab it and you go all the way down and hold it right there, and then she can kick out. And also we can go the other direction too. You really just figure out which direction you find most of the tension at, or most of the restriction at, and then you kind of hold it. I like to work also the backside into the hamstring area, and obviously we can work on both if you'd like, but at the same time the one that's most relevant is going to be the one actually next to the IT band here. Obviously I switch knees and that's just for camera angle. So I'm going to hold this here. I'm actually going to bring her leg up and then down, and we're just going to do the same type of style we did before. Just kind of holding and getting slide between the tissues, because sometimes things get hung up there. And just like when you're assessing the joint motion, you want to see where the restrictions are at, and just mainly try to free those up slightly. Again, the point is to increase pain-free range of motion, and then we can do some rehab to strengthen and improve the movement pattern after that. Now the next area I like to work is the adductor. It's on the front side here. There is obviously a large group of adductors, but generally speaking, again, we're just freeing up motion between some of the adjacent muscles in the area. And if you feel, when you move somebody, you can kind of feel which things are sliding, which things are sticking, and so on. This takes a little bit of time to develop, but you can feel things relatively slide amongst each other. We want it nice and smooth. So since this is a large section of the thigh and the leg all the way down to the knee, it's important that it's worked as well. So again, I'm going to broad contact here into the webbing and also into the thumb here. And I'm going to move her into flexion. This is hip flexion. And if I really wanted to add a little bit more stretch onto the adductors, I can move her into this direction right here. Okay? This is pretty tender on people often. So a lot of times you have to make sure you're not really gripping with the skin and just pulling at it. You just have to kind of sink in and grab it and just be really gentle with it and look at their face and realize that they're not going to fall apart. You can see her, you can feel her almost crying in this video, and she doesn't even have a knee injury right now.
So these are the muscular techniques or release techniques that Laura chose. I gave her free range to choose what she wanted to, since she typically does a lot of her own work anyways before she runs and lifts. So the only one thing I wanted to draw attention to here was her excessive lumbar extension, and she does it on a couple other things that we do in this video. So I wanted to draw attention to the excessive extension, and that does happen a lot with runners as well as lifters. So just be aware, I don't endorse that part of this video, and also her posture of her neck. All along this, obviously the whole point of releasing the tissues is to loosen them up slightly and get rid of the gristlies and scar tissue component. There's not really much to say on this, so I thought I would tell Laura that the audio is off and tell her some jokes and just see how she responds, so enjoy the show. So she's going to start on her quad group.
It's going to be amazing. I'll be like, hey Laura, what do you call a guy who shows up at your door with no legs?
What do you call him?
Matt.
How does that even make sense?
Next, we're going to go into the adductor group.
What do you call a guy who's on the wall with no arms and no legs?
On the wall with no arms or no legs?
Yeah. Art.
What? Where are you getting these very sick jokes?
How come at the Halloween party there was no candy? Because everyone was a goblin.
Then we went into her hamstring.
So if you're in the restroom, and you're American when you walk in the restroom, and you're American when you walk out of the restroom, what are you when you're in the restroom?
Un-American? Un-American?
You're European.
Now I fast forwarded a little bit just because she was focusing mainly behind the knee, but you can go up the thigh as well on the backside.
Now the SI joint, you can assess while being face down. Now let's just say if we're looking at this side right here, I'll usually put the base of my hands right into here onto both sides. Usually where the people have dimples is where you want to put them. And you'll feel like the bony area down there. And we're just really just assessing which one moves better, or if which one doesn't move at all. Based upon that, we can add a little bit of overpressure. Let's just say this one's not moving well. So we can actually take this section of our hand, twist it here, press away, and then we're just going to oscillate it. Okay, there's obviously many different ways to assess joint motion or SI joint motion, but in the case of IT band, this is one I like to choose. We also can adjust the adjust the SI joint as well. Gentle oscillation is one of the safer ways to mobilize a joint because you're not really jamming through the thing. And oftentimes when people get up, they feel much looser into the pelvic ring. Next, we'll show an adjustment here of the SI joint. Okay, I don't expect any of you to do this on your own. Okay, just roll them like this. We're going to find that same section where they have that dimple and press through. And I don't know if the mic got that. We got the SI joint there on that one, so hopefully it frees up motion of the pelvic ring. Next, we're going to actually mobilize the hip in a different way. We're going to go in axial distraction, and we're going to see first, we're going to pull right here a little bit just to see if there's any restrictions of motion into this direction or that direction. So what we can actually do is we're actually going to pull this way and do it very quickly, or you can just go in gentle oscillations. She probably has to hold the table. Hold the table for me to make sure I don't pull you off, because we're going to do a real quick yank here. But you can also do it in oscillating fashion again. So I'll do some oscillations, okay? And again, finding that restriction, whether it doesn't want to go inward, which on people with FAI or femoral acetabular impingement, it's not going to want to, or external rotation, which isn't uncommon as well. I like to grab above the ankle here, because if you go below the ankle, you'll adjust the ankle, which isn't necessarily bad, but at the same time, if we're not trying to, then we won't. Okay, so hold that table there. So now we're just gapping that joint.
Now, after freeing up motion, I like to stabilize the frontal plane. So we're going to use the lateral wedge exercise. And this is, again, to stabilize the knee, hip, and pelvis again, now that we have more pain-free range of motion. Some of the basic cues of this exercise are attain a wide stance, breathe, press into the wall or press the wall away, have the shoulders and belt lines parallel to the ground, and then slightly unlock the knee on that stance side. Make sure you're breathing continually throughout this exercise through the abdominal region. Unlock that left knee slightly. Good. Keep that belt line. And back down again. Last one. And go again. Unlock that left knee. There you go. Keep that belt horizontal to the ground, parallel to the ground. And relax. Now, I chose the bird dog to do with Laura because mainly it's really common for runners to be in extension patterns, and you'll see throughout this demonstration that I was actually going to go over just showing perfect form, but she needed some correction, so I took this into a different route. I'm actually correcting her as we go. So just know that the extension she has in her back or low back is not intended. We're trying to clean that up, and it's really common to have hip conditions such as IT band, hip flexor tightness, and many, many more in correlation with a weak trunk or core region, quote unquote. This exercise should help out with finding that correct posture and attaining it with running as well.
All right, so arch your back for me, and then other way, and then other way, and then find the middle. There you go. So now, make sure that this section right here, I shouldn't be able to press, so I want you to press up against me a little bit. There you go. I want you to press the shoulders through like you're going to press the ground away. Good. So now in this position here, I want you to drive one leg out really slow, lead with the heel, and act like you have a cup of coffee on your back. So now you should make it so you're actually, so I want you to contract this section so hard, drive the heel straight through that corner over there. You should feel like your cheek is almost going to spasm. Now take that right hand all the way out. Crush that thing. Good. Again, hard, hard, hard. I don't know if you can feel, but this is falling apart on you here. Okay? So go ahead and go down again. Okay, so find upward, find downward,
and then find the middle. Good. Let's do only leg drive this time, okay? You go. So right there again, you're arching at this part right here, okay? So let's come all the way down again. This one might be just an assessment part, okay? Press up on me. There you go. So right here, I want you to press really hard into my hand. Fight me with your abdominal wall, okay? With your breath. So breathe in, and then out. One more time, in and out. Normally I do this with both hands on both sides. Okay, so hold that position like you feel like it's the end of the breath right there. You can still breathe though. So go ahead and drive that one heel out. Remember, you have a cup of coffee on your back. I don't want you to lose that coffee at all. If you spill it, I might make you clean my white carpet here, okay? That's better. Okay, so give me that right arm. All right, so you're arching a little bit there still. It's okay, this is something we can work on. So go ahead and slide them back really slow. You got that coffee on you. So for you, I'd probably have you reset every time. So let's find the upward, let's find the downward, in the middle. Give me a couple breaths all the way out. Like you're blowing up a balloon through a little straw. Good. Let's try the right leg this time. Oh, so there's a lot of twisting there on this one. Bring your, let's see. So right here, I want you to press down into my hand. Drop, 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 drop. Give me a little bit of pressure there. Good. Okay, so now you've stopped rotating, but you're arching a little bit there. Did you feel the rotation a little bit? Mm-hmm. Okay, let's start again. So this time, rather than opening up your hips, I want you to drive that heel straight through the wall. And even if you do it, can't do it as high up, like all the way to the glass, just do it to where, like, you know where cockroaches run on the side of the room? Yeah, I want you to drive it towards the corner. So go ahead. There. That's better, but contract this left cheek for me here really hard. It's not working for you. So if I was on that side again, I would, well, I'll just take you here. Go ahead and press into my hand here. Good, good, good. There. So that looks better to me. I don't know if you can feel a difference. Mm-hmm. So let's try this left arm here and see if it degrades anymore. Crush that toothpaste. Real hard. Good. Straighten that leg. I see you relaxing that leg. Drive that heel. I'd see your knee straight if you were doing it. Good. I'll take that. And then slowly return. So this is the bird dog, and obviously it takes a lot of correcting. It is a finesse one, so let's start through the steps one more time. So find your upward, find your downward. Then you are going to balance cup of coffee on your back like you are on a nice white shag carpet and you like your host. Okay? So exhale. Good. I think you can get a little bit, press up into my hand here. Good. Exhale again. Lock that down. Good. Let's drive the heel. Pick either one. Remember, go where the cockroaches run this time. Right hand. So there's still a little bit of arcing. Again, this is an exercise that sometimes takes some time. But after about 5 minutes, you see this is still not perfect, but she's getting a little bit more every time. Go ahead and bring that down. So that's the bird dog. So deadlifting is one thing we like for IT band syndrome just because it strengthens the backside, which is the hamstrings, the glutes, the spinal erectors, which are really important to decrease in internal femoral rotation, which we talked about a second ago. Okay, so go ahead, Laura. I want you to, let's see what you got. She's deadlifted before, so I'm going to let her have a little bit more free range. It looks pretty good so far. So normally when I assess a deadlift here, I like to see first from this position, is she rounding the back at all? Is she extending excessively? Is she using the lumbar spine excessively, and are the hips above the knees? And it looks like they are. So I'm going to slide around this way and see if she has any relative knee cave. And it looks pretty good so far. Now I'm just going to let Laura rep these things out a little bit here and just let you know, I didn't go over many cues in this video, but I do have a whole entire video on some of the techniques for lifting the deadlift. Now, a lot of people will be afraid of deadlifting, but we found that with increasing posterior chain strength, or the backside, it helps out a lot with a lot of the posture and forward lean that we have to have with running, which will decrease then extremity types of conditions, tendinitises, friction syndromes, and so on, like we're dealing with IT band syndrome. So go ahead and find that video. I'll put a link in the description to where you can find that video right here.
Now for those of you who stayed, we're going to do some really cool things with actually the anatomy right here, just to show you what's going on with IT band syndrome, because again, you watch those nice self-help style videos and how to quick fix things, but realistically you got to understand how the knee works if you're going to address IT band syndrome. Now the IT band is a dense structure, a fibrous band, which goes all the way up to the outer part of the hip and actually runs alongside the knee here again. So it sits on right on top of the lateral quad, which is called the vastus lateralis. And as it goes down to the knee, it also runs over a bursa in and amongst these bony areas. Here's the lateral meniscus again. So the bursa can be really pissed off against the lateral femoral condyle, which is right around here. A bursa, if you don't know what it is, it's a normally occurring structure. Think of a water balloon right here that is just getting crushed a little bit too much. Now you might wonder what is creating IT band syndrome anyways, and a lot of times you'll find on the web that you'll look up and you'll find tightness of it. But realistically, this IT band is a really, really dense band which doesn't want to stretch. It creates lateral stabilization of the knee and the hip. So it needs to be tight and resistant of stretch for a reason. Since this does come way up here, there's a strong correlation with hip issues, core instabilities. Is your hip functioning well? There's a lot of things up here which will create this section down here to feel tight and also compress on this bursa. With the knee, it's typically called the red-headed stepchild of the extremity because it is a real simple hinge joint. It goes mainly one direction. There's not much to it. It isn't like this, and it doesn't like being twisted either. So a lot of times if we require these two movements in this area, we're going to piss off the structures which cross the knee, the bursas, the meniscus, and a lot of the integrity of the knee will degrade when we don't have this portion up here working. And as you see, if we turn this femur in, this internal femoral rotation creates a shearing force at the knee, which a lot of times it doesn't like. Now, a lot of people will say that the way you rehab this is to massage out the quad, the lateral quad, strip the IT band with like a foam roller and things of that nature. But realistically, it comes to, can we keep this thing from rotating in lateral bend? Can we make it so this IT band can do less work? Can we make it do less work and make it feel less tight so it doesn't crush this bursa and these structures on the side here? The magic of rehabbing really comes from, can we get this whole limb to stack well? Now very quickly, I'll go over the idea of rehab for knees because I do have an entire podcast on this, and there's a few analogies that we use with the knee. One is the door hinge, the other one is the columns, and also we have the screw hole mechanism. There's all these things to be considered when rehabbing the knee, but for the most part, a lot of people, I'd say a strong majority, we can address the knees as long as nothing's torn excessively, nothing surgical, that we can address it by improving stacking of the limb. And this starts with the core. It starts with breathing. Oh, he just fell down. Breathing starts with the diaphragm, the pelvic floor, the entire area right here. And as you see, it's a shell. There's nothing holding this together from a structural or bony standpoint other than the spine and the core and the top and bottom of it, which are the pelvic and diaphragm, pelvic diaphragm and diaphragm. Now, once we control this, we move down to the hip. The reason is because when this thing gets sloppy, and imagine I'm pulling this thing up, and let me grab a little tool here. So now we have a band. Imagine this is attached, say, right here. If I'm pulling, if this thing elevates, this also brings the band up, okay? So tension changes on muscles which are going down to the knee based upon pelvic position, okay? This happens on the front and it happens on the backside too. So the hamstrings are not excluded from this. Imagine now I'm taking this here and I'm back here like this, and the hamstrings attached down into this area right here called the ischial tuberosity. So now say we were rotating the pelvis this way, you can see tension developing on the band right there, which is again going past the knee to the other side of it. Okay? We have to control this, we have to control this, control the ilium in the pelvis, control the hip, and then we get into the knee. And obviously we can go into the ankle as well, and there are a couple of other factors, but if you're only doing rehab specifically for this region, for this right here, you're missing the boat. So I hope this was helpful to you guys. Give me a thumbs up if you like this video already. I tried to make this the most comprehensive video on IT band conditions and knee conditions that I possibly could for runners. Obviously, if you do have IT band syndrome and you're not a runner, this almost does apply as well, except for there are small little differences. But remember, we're rehabbing in the entire body to get rid of this, and this happens with a lot of other conditions as well. So again, if you want to hear the theory of rehabbing the knee in its entirety, we do have the Performance Play Sports Care podcast. So just go to p2sportscare.com/podcast, or you can find it and I'll place it in the link below, just as a few other helpful links for you.